Yes, Dr. Someshwar, it's on live now.
Yeah, thank you, Ashwin. Ma'am, with your permission, shall I start?
Yes, please.
Yeah. Thank you, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do comment your queries in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. N. Kathya, who is a director at Dr. Nagalakshmi Laparoscopy and Test Tube Baby Center, Produttur. She have completed her medicine and MS in obstetrics and gynecology and fellowship in IVF as well as fellowship in laparoscopy. And her field of interest are fertility enhancing hysteroscopic and laparoscopic procedures and IVF. So with this, we welcome you for today's webinar, ma'am. And today's present webinar is streamed through the Shield Connect, which is the digital initiative of Shield. I request all the delegates, please do visit Shield Connect webpage. If you miss any part of the program, it will be available in the Shield Connect page in the YouTube as well as Shield Connect webpage. And coming to the today's topic, as we know that PCOS is the most common cause of annullatory fertility problem in women of reproductive age, with prevalence as high as 40 to 75%. So there are different treatment modalities for increasing the chance of pregnancy in PCOS patients. So now, without wasting much time, let me turn over the time to Dr. Kathya ma'am to talk on improving the ART outcomes in PCOS. Over to you, ma'am. Yes, ma'am. You can start this.
Can you see my screen?
Yes, ma'am. I can see the screen, ma'am.
Okay, I thank the organizers for giving me this opportunity. And now I am asked to talk about improving the ART outcomes in the condition of PCOS. So here I go. We all know that PCOS is the most common endocrine disorder affecting the reproductive age, and which causes anovulation. And anovulatory infertility causing due to PCOS causes about 70 to 80% of the cases. So in Indians have amongst the highest prevalence rate in the world of PCOS, that is 41% in the reproductive age group. So what are the indications of ART in PCOS? Poor response or lack of response to ovulation induction. So if patient doesn't respond to the normal ovulation drugs, then we go for IVF. And also for if there are coexisting factors like male infertility, tubal factors or unexplained causes, and failed IUI cycles or failed ovulation. These are the conditions where the patient of PCOS requires ART, that is IVF. So coming to diagnosis, we all know that there are three criteria in which we can diagnose PCOS. That is, one is Rotterdam criteria, one is Androgen Excess PCOS Society, and one is NIH consensus. Out of these, we have they have finally outlined 4 types of PCOS patients. One is type A, type B, type C, and type D, where type A consists of all the 3 factors, all the 3 features of PCOS are seen in them. That is hyperandrogenemia and irregular like anovulation, ovulatory disorder, and also polycystic ovarian morphology on ultrasound. Whereas in type B patients, the ovaries look normal on ultrasound, but there will be hyperandrogens and also anovulation or ovulatory disorder. Type C are the patients with polycystic ovaries and high androgens with regular cycles. Whereas type D patients are with polycystic ovaries and irregular cycles, but they don't have features of hyperandrogenemia or hirsutism. So this is very important for us because the type of PCOS, the type of patient, it depends upon if the patient falls in which type of PCOS, the response to ART and also the response to ovulation induction differs in these patients. That we'll see further. So what are the pathological mechanisms affecting reproductive outcome in cases of PCOS? PCO patients are 50% of them are obese, and they have excess androgen, and also they are at a high risk of ovarian hyperstimulation, and there is hyperinsulinemia, and there is excessive LH, which causes cellular level or molecular level of implantation failure, fertilization failure, or recurrent abortions. All these risks are there in cases of PCOS. So all these can be treated accordingly depending upon their condition. So if we come to treatment part of PCOS, first option we have is usually there is anovulation. So we target mainly the ovulation induction. So ovulation inducing ovarian stimulation or ovulation induction is done by various drugs. The few drugs we have which are available for us in treating PCOS, or one is metformin, one is ovulation induction drugs, one is gonadotropins, FSH and HMG, one is GnRH agonist and antagonist, which are helpful in the IVF cycles. So first line treatment is basically lifestyle modification, where there is targeted counseling on the weight loss, which can be taken up to patient can be counseled to follow a lifestyle modification alone without any drugs for about 6 months of period, after which we can start with ovulation induction if that doesn't work out. So along with that, along with counseling of weight loss or lifestyle modification, we can also add on ovulation inducing drugs like letrozole, metformin, or clomiphene citrate. And the second line drugs are hormone injections, that is FSH and HMG injections, where they come as second line drugs because of their high cost and also high risk of increased risk of multiple pregnancy than first line drugs. And when they are resistant to hormone injections, or when there is no result with hormone injections, even though ovulation has occurred, or if the LH levels are very high, one more second line plan of treatment we have is the ovarian drilling, where again the cost is high. And after ovarian drilling and again ovulation induction, if there is no response of the patient, then the third line management will be IVF or ICSI. So this is again showing the flowchart of treatment pattern. First, the BMI is concentrated. After that, the ovulation induction drugs are put. This is the algorithm showing treatment of infertility, where the first line drugs are letrozole, clomiphene plus metformin, metformin alone. Second line comes the gonadotropins or ovarian drilling. The third line management includes IVF. So here are a few evidence-based guidelines which we can follow. That is recommendations regarding letrozole. Letrozole should be considered first line in women with PCOS with anovulatory infertility. Where letrozole is not available in some countries, we can go for other ovulation induction drugs. And risk of multiple pregnancy appears to be with less with letrozole compared to clomiphene citrate. And this is the dosage protocol of letrozole. It is started as 2.5 mg to 5 mg per day. There are three types of protocols in which letrozole can be used. One is a standard protocol where we start letrozole 2.5 to 5 mg for 5 days, starting from second day to fifth day. And then, or it can be given for extended letrozole protocol, which can be given from second day to 10th day, 2.5 to 5 mg. Or third part is the letrozole step-up protocol, where it started with 2.5 mg on second day and goes up to 7.5 mg or 12.5 mg on fifth day. So after the letrozole, we have to see for evidence of ovulation, like monitor them on ultrasound for follicular growth and release. And it can be combined with IUI cycles, or it can be advised natural cycle or timed intercourse. So this is about clomiphene citrate, where we start with 50 mg and see for ovulation. Clomiphene citrate can be increased up to 150 mg per day for 5 days. Usually there is a thin endometrium associated with clomiphene citrate, where we can switch to letrozole if there is a thin endometrium. These patients can also be monitored for follicular growth on ultrasound to stabilize the dose of ovulation. So CC plus metformin, what does the evidence say? CC could be used alone in women with PCOS with anovulatory infertility, and metformin can also be used alone in women with PCOS. If metformin is being used for ovulation induction who are obese, that is BMI is more than 30, clomiphene citrate can also be added to improve ovulation, pregnancy, and live birth rates. And CC can be combined with metformin rather than persisting with CC alone in women with PCOS with the CC resistant cases. CC resistance is where there is no ovulation even with the maximum dose of clomiphene citrate. And coming to metformin, there are usually gastrointestinal side effects with metformin that are to be addressed to the patient before starting the dose. And also it should be started at a low dose like 500 mg OD and gradually increased in 1 to 2 weeks up to 2000 milligrams as per the patient's requirement. And long-term use of metformin can cause B12 deficiency. But now we have drugs available where B12 is also included in the drugs along with the metformin, which can be prescribed, which prevents this side effect. Next, coming to gonadotrophins. Gonadotrophins, according to recommendations, gonadotrophins are used as second-line pharmacological agents in ovulation induction. And these should be considered first line in the presence of ultrasound monitoring only, and also taking into consideration the cost and also the risk of multiple pregnancy. And gonadotrophins, where available and affordable, should be used in preference to CC combined with metformin to improve the ovulation, pregnancy, and live birth rates. Gonadotrophins with addition to metformin could be used rather than gonadotrophin alone, because metformin also looks into the hyperinsulinemia and hyper LH status of the body. So gonadotrophins can be opted, or laparoscopic ovarian drilling can be opted. Both can be opted simultaneously for as second line drugs for ovulation treatment of infertility in PCO. So what does the recommendation say about laparoscopic ovarian surgery? It could be second line therapy for women with PCOS who are CC resistant with anovulation. And the surgery could potentially be offered as first line treatment if laparoscopy is indicated for another reason, like a tubal factor or a presence of a polyp or associated with myoma. These are conditions, or we suspect any periovarian or periuterine adhesions. In these cases, laparoscopy is taken as first line treatment in cases of PCO. And coming to this study has concentrated on the types of PCOS where cumulative live birth rate after IVF in patients with PCOS, whereas phenotypically hyperandrogenic patients have a less cumulative birth rate, ongoing birth rate, and also live birth rate compared to phenotypically normal PCO patients. So this shows the picture, whereas only PCO morphology, the live birth rate is 53%. Whereas PCO morphology with hyperandrogenism, it has gone down to 25 to 27%. And metabolic syndrome definitely has a negative impact on female fecundity and also in patients with PCO. It also affects the results in third line procedure, that is IVF also. IVF is a rare thing which is done in very few centers with a low success rate, whereas this is a procedure where the smaller follicles are retrieved with the immature cumulus oocyte complex, and the maturation is done in the lab and then followed by ICSI. This can be helpful in patients with PCO where there is a poor response and there is no proper growth of the follicle. And coming to agonist or antagonist cycle, it is well proven now that antagonist cycles are far better than agonist cycles in PCO, as there is decreased risk of OHSS, and also OHSS can be easily handled in cases of antagonist cycles. Urinary or recombinant, any FSH can be used for stimulation in IVF. And exogenous LH is not necessary in cases of PCO, or exogenous LH has a limited role when compared to FSH or HMG. And even metformin therapy during IVF has also shown to increase the success rates in patients on stimulation for IVF. So trigger ovulation trigger, preferably it is the GnRH agonist, where we follow the antagonist cycles in cases of PCO, which prevents the incidence of OHSS. And also PCO cycles, freeze-all protocol is better than fresh transfers, because the OHSS, if any occurs during the post pickup, it can be handled easily. So this is a graph showing individualization of ovarian stimulation IVF. Here, as we are talking about the PCO, it is more AFC with more AMH and high ovarian reserve, and where we expect high response with antagonist, high response, and so go for GnRH antagonist protocol, mainly to minimize the OHSS risk and also avoid the HCG trigger. And coming to OHSS, we can predict OHSS with few factors like young PCO patients and lean patients with classical PCO morphology on ultrasound, and also more AFC and high AMH. And during stimulation, highly or rapidly rising E2 levels also indicate the risk of OHSS. So obviously, there is increased risk of OHSS in PCO patients when compared to controls. And one important study here we show is the myoinositol, when given 3 months prior to ovulation induction, has also controlled the incidence of OHSS. Mainly, myoinositol has uh, uh, decreased the peak E2 level raised during the stimulation, but also significantly decreased the number of smaller follicles, resulting resulting in decrease in the number of lesser or smaller follicles less than 14 mm, which are the main cause for OHSS. And also it has significantly decreased the vascular permeability. Totally, it has a key role in prevention of OHSS in PCO patients. So it is myoinositol 2 grams twice daily for 3 months before ART has improved the oocyte quality and also increased the percentage of M2 oocytes, and has also decreased the percentage of degenerated oocytes, and also increased the grade 1 formation of grade 1 embryos. So if we come to OHSS, definitely the things we can follow are provenly recommended things: reducing the gonadotropin dosage and giving an agonist trigger, adding metformin and myoinositol, and also using cabergoline to suppress the vascular endothelial growth factor, and which can be helpful in interventions to prevent OHSS. If we can, by reducing gonadotropin duration of stimulation, and adding HES after pickup, and also converting all the cycles into freeze-all cycles, which are not very useful as of now, or individualized control ovarian stimulation, and following posting, and also which is a newer drug, vasopressin receptor antagonist usage. These are yet to be research yet to be done in preventing OHSS. So thank you for patiently listening about this topic. Thank you so much. Hello. Hello.
Madam. Good evening, madam.
Good evening. Good evening.
Right. Nalla right, madam. Someshwar sir. Hello. Someshwar sir. Someshwar sir. Okay, madam. Wait, madam. Someshwar sir.
Hello, Malareddy.
Yeah, madam. Hello. There is a connectivity issue, madam. So Someshwar sir will respond because he will take question answers, madam. Someshwar sir.
So I'll call Malaredi. I'll call Someshwar. So he'll be coming soon.
Hello. Hello.
Yeah, hi Someshwar.
Yeah.
Yeah. So doctor is
Sorry, yes,
done
sir.
with the presentation.
Yeah. There was a connection disruption. I couldn't unmute. Thank you, ma'am, for the wonderful presentation.
Thank you.
It was very honor and glad to hear you, ma'am. And ma'am, if you allow me, then we'll take the questions, ma'am.
Yeah, okay.
Yeah. Thank you, ma'am. Ma'am, we have a first question. That is step up or step down in PCOS.
Step up protocol.
Thank you, ma'am. And I think from the same delegate asking for GnRH agonist trigger when to and any benefit in PCOS.
Definitely, GnRH agonist trigger has a benefit if it is an antagonist cycle. It totally prevents almost 99.9% prevents incidence of OHSS. 95% prevents OHSS. So definitely, GnRH agonist is the first option for patients with PCO.
Thank you, ma'am.
Okay.
We have one more question, ma'am, from the Dr. Sudha, asking that how to predict OHSS in PCOS.
In cases of IUI cycles or ovulation induction cycles, that is not a IVF. If you are suspecting OHSS, like so many follicles have recruited, then you can go for an E2 level and then convert to IVF if the E2 level per follicle is more than 300. Or if the E2 level is more than 1500, you can convert it to an IVF cycle. Or stop the stimulation and suppress the cycle with the GnRH antagonist. Whereas in IVF cycle, to prevent OHSS, first of all, you should predict OHSS in cases of lean patients and high AMH levels with high follicular AFC count. And once the stimulation has started, start with a lower dose and gradually increase the dose of hormone injections, and also go for a agonist trigger, and also go for a freeze-all cycle so that managing OHSS post pickup with the antagonist. If we follow these things and also adding cabergoline after pickup, then we can prevent OHSS.
Yeah, thank you, ma'am. Thank you very much for the son. And there are no more questions from the delegates, ma'am.
Okay.
If you allow me, then we can close this webinar.
Okay, fine. Thank you.
Yeah, thank you so much, ma'am, for the wonderful presentation. We are very glad to have you, ma'am, and we look forward for your continuous support, ma'am, for
Okay,
the
fine.
educational activity. Thank you very much, ma'am.
Thank
Have a
you.
good day, ma'am, and also thank all the delegates for their active participation. Many
Okay.
thanks from the Shield team.
Okay.